So welcome back, everybody, and thank you for staying with us for this last presentation of the conference. Our next session focuses on psychological and behavioural health of children and adolescents with CKD and is presented by Rebecca Johnson. Rebecca is a paediatric psychologist at Children's Mercy, Kansas City, and a professor of pediatrics, University of Missouri, Kansas City School of Medicine. She received her PhD in clinical child psychology from the University of Kansas and completed her internship and postdoctoral fellowship in clinical child and pediatric psychology at Children's Mercy, Kansas City. Rebecca is board certified in clinical child and adolescent psychology by the American Board of Professional Psychology and has over 15 years of experience providing clinical psychology services to youth with chronic kidney disease, including those on dialysis and post-transplant. And her research and professional activities focus on improving the psychosocial care and quality of life of children with CKD and their families. So I will now hand over to you, Rebecca.
Well, good morning to those of you who are in the United States and good afternoon to everyone else, or maybe good evening. Thank you for that very nice introduction. First I'll start with, I have no financial disclosures. And I'll start with objectives. So the objectives of this talk include being able to identify ways CKD may affect neurocognitive functioning, discuss how it impacts the emotional and behavioral health of children and adolescents and patient and family quality of life, and identify some strategies that support the behavioral health of children with CKD. So what I'd like to do first is talk a little bit about what is known and not known about the neurocognitive effects of pediatric chronic kidney disease, how CKD may affect emotional and behavioral health of children across the spectrum of stages of CKD, the impact it has on patient and family quality of life, and then, as I mentioned earlier, some strategies that may promote adjustment to chronic illness or improve quality of life for these children and their families. All right, so I'm going to start by talking about neurocognitive functioning and what we know about that. And I'm going to kind of go from mild to moderate CKD and then move into end-stage kidney disease. And so for mild to moderate CKD, a lot of what we know has been through the research of the CKID study, which some of you may be familiar with. CKID is a longitudinal prospective cohort study of children with mild to moderate CKD. It's been going for over 15 years, and we've enrolled over 1,000 participants in the study. And so in 2016, we looked at the neurocognitive functioning of 124 preschoolers who'd been enrolled in the study who were aged 12 to 68 months. And reassuringly, we found that they had average functioning overall. So median scores on the standardized measures that we use to look at development and cognitive development, social development, things like that, placed in the average range. But the distribution of scores skewed toward delayed cognitive development. So when we looked at how the scores were distributed, they did not look like a normal distribution, but they tended to skew a little bit lower. 27% of the sample were at least one standard deviation below the mean for IQ. 20%, and to put that in perspective, we would expect about 16% to be one standard deviation below the mean. 20% showed significant variability in their sustained attention. 30% had elevated parent ratings of executive dysfunction compared to same age peers. And if you're not familiar with the cognitive executive functions, that's kind of a set of cognitive processes such as attention, memory, planning and organization, self-control. So for example, being able to inhibit impulsive behaviors and manage your own behavior. And so we found that about 30% had parent ratings that suggested some dysfunction with those executive functions. And then we found that higher GFR and the absence of anemia were associated with somewhat better function. So that's what we found for the preschool kids. When we looked at school age kids, in 2011, we had 368 in that sample, ages 6 to 16. And results were, again, reassuring in that overall cognitive functioning was within the average range. But we saw the same pattern of findings where a higher percentage were kind of in that at-risk range. And we had a distribution that skewed a little bit lower than we would expect for a normal distribution. So 21 to 40%, depending on which measure you looked at, were at risk for some deficits in intelligence, executive functioning, and attention regulation. And we found that proteinuria was associated with lower IQ and increased attention variability. Higher GFR served as a protective factor for executive functioning. So that was kind of what we found for the school age kids. We also looked at our data very much more recently. It's still under review. We looked at it longitudinally. And again, it was reassuring in that over an 8-year time period, we did not see any major deterioration in neurocognitive functioning for kids with mild to moderate CKD. And this would encompass only those kids with mild to moderate disease, not with end-stage disease. But that said, we did find that for those who had significant changes in their GFR, that was associated with lower IQ and some deficits in executive functioning. One factor that can affect neurocognitive functioning is sleep. And we know that kids with CKD have high rates of disordered sleep or problems with sleep. And so we did a study in 2019 of 1,030 participants who were enrolled in the CKID study. And as we suspected based on the literature, we did find high rates of fatigue, sleep disturbance, and low energy. And with regard to neurocognitive functioning, we found that report of low energy was associated with lower with parent-reported problems, associated with parent-reported problems of executive functions, as well as the participants' actual performance on tasks of working memory, inhibition, and problem-solving fluency. So in the CKID study, mostly before the pandemic, we brought kids in to do standardized neuropsychology measures of their functioning, and we also obtained parent ratings. So we were able to see that sleep impacted not only what their parents reported in terms of their abilities, but also their actual performance on tests of those abilities. We've also found that there are a number of disease-related covariates that are associated with neurocognitive functioning. So longer duration of CKD is associated with poorer attention and executive functions. Higher casual blood pressure and highly variable visit-to-visit systolic blood pressure is associated with lower nonverbal IQ and problems with set shifting, which again is a type of executive function. And variability in blood pressure has been found to interact significantly with lower levels of bicarbonate to contribute to lower executive functioning. So taken together, findings indicate that there is potential for neurocognitive dysfunction, even in mild to moderate CKD. Although, again, it's very important to note that many of these kids do well and have scores, well within the average range. And it's important to note that some of these findings may or may not be clinically significant. So for some of these, findings, we have subtest scores that differ by 1, 2, or 3 points, and that's statistically significant, but we don't know how that translates into kind of real world performance. It might, but it's unclear. And then just kind of a note that CKID is homogeneous in terms of disease severity. So we have very clear parameters for GFR at study entry, but not for underlying conditions. So it may be that specific subgroups are more or less at risk for problems with neurocognitive functioning. So for example, kids with ARPKD or lupus may be at less risk, and kids with other types of underlying disorders may be at more risk for neurocognitive functioning. And we don't always have, even though it's a fairly large sample, enough kids to make those types of comparisons. And then again, with mild to moderate CKD, in 2018, there was a really nice meta-analysis of that encompassed really almost all studies that were analyzable, and looked at neurocognitive functioning in CKD. They found that the most commonly used measure of intellectual functioning was the Wechsler. And just for your reference, the mean of the Wechsler is 100, and standard deviations for that test is 15. And for children with mild to moderate CKD in this meta-analysis, compared to the general population, they had full-scale IQ scores that were about 9 points below the mean, or their mean IQ scores were about 9 points below the general population, and you can see verbal and performance IQ were 8 to 9 points lower. So that's about half of a standard deviation or more. So that's a fairly significant and really clinically significant finding. It differs a little bit from what we found in CKID, but for their mild to moderate studies, they included I think a little bit more variability, and probably had kids, more kids in that stage in 3 or 4. So that was a really interesting meta-analysis. They also found that lower scores on tests of memory and attention, but not parent-reported executive functioning, that placed in the average range for this meta-analysis for mild to moderate CKD. So moving from mild to moderate into end-stage kidney disease, you see a very different picture. Studies consistently show that children on dialysis perform more poorly on measures of neurocognition than children with mild to moderate CKD or transplant. So dialysis in particular, we tend to see lower scores on many measures of neurocognitive functioning. There's some evidence that earlier age of onset of end-stage renal disease is associated with poor outcomes. However, it's important to note that modern outcomes for kids who are diagnosed very early in life are certainly much better than more historical ones. And one of the reasons for that is the improved nutrition, which is thanks to many of you and all the work that you do. So kids tend to have much, over the last few decades, improved nutrition. Aspects of treatment have improved. Comorbidities are addressed and managed more frequently. There's also evidence that fewer months on dialysis and younger age at transplant are associated with better outcomes, neurocognitive outcomes for those with end-stage kidney disease. So basically, the less time you spend on dialysis or in that uremic state, the better that probably is for your brain. And then comorbidities play an important role. So things like, proteinuria, hypertension. If kids have history of seizures or prematurity, those can also play a pretty significant role with neurocognitive functioning. And just to kind of put this in a little bit of perspective, Brad Wardy and I at Children's Mercy a few years ago did a study where we looked at kids who had been diagnosed as infants with end-stage renal disease. It was a small sample. It was a single center study, of course. But we were able to compare their performance on neurocognitive measures to their siblings in kind of an effort to control for environment and maternal education and some of those things. And we found that on average, the patients scored a full standard deviation lower than their healthy siblings on measures of IQ and on academic achievement and things like that. So certainly there can be a very significant impact on neurocognitive functioning for kids who have end-stage renal disease early in life. And then kind of circling back to the meta-analysis that was published in 2018 by Chen et al., they found that for children on dialysis compared to the general population, a difference in full-scale IQ of 16 points verbal IQ was -14 and performance about 15 points below the general population. So that's a full standard deviation, and that's a very significant finding. And then transplant recipients had somewhat better outcomes. So, again, their full scale and performance IQs are still, well below their mean scores, but verbal IQ looked a little bit more robust than patients on dialysis. And so before I move on to emotional behavioral health, just a couple, final thoughts. I think that one of the things that we're really excited about in the CKID study is in our current iteration of the study, we've added to the aims to begin following the patients into renal replacement therapy. So when you look at the literature on neurocognitive functioning, you have the CKID study and a handful of others that have looked at mild to moderate disease. And then you have a lot of small sample studies looking at kids with end-stage kidney disease, but no one has followed kids prospectively from mild to moderate into end-stage kidney disease. There's very, very little in the literature that have done anything like that. And so we're really excited that we can follow these kids prospectively and hopefully gain more knowledge about what factors predict decline in neurocognitive functioning. Of course, the pandemic has thrown a bit of a wrench into that, but hopefully we will be able to persevere with that aim of the study. The other thing I want to mention is that, a lot of the research that I've discussed are describing associations between, covariates or predictors and neurocognitive functioning, but we still really have not a lot of knowledge about what the actual mechanisms are that cause changes either in neurological development or in performance, neurocognitive performance. And so hopefully, as we move forward and we will get more research on what the actual mechanisms are that cause deficits in neurocognitive functioning. All right, so that's kind of the neurocog part. And so for the second part of the talk, I wanted to move into talking about emotional behavioral health. And kind of structuring this in the same way, kind of starting with mild to moderate CKD and in the preschool age again. So in that study that we did with preschool kids, median scores on parent ratings of social behavioral functioning were within the average range. So again, very reassuring. We found that parent ratings of adaptive behavior were in the low average to average range. So again, we see kind of that skewed distribution where the median scores are still placing in the average range, but our distribution tends to skew a little bit lower. And then a greater percentage than expected, 37% were in the at-risk range for adaptive behavior problems. And then we published a study of longitudinal parent ratings for school-age kids. So we had 845 in this sample, and we used the behavior assessment system for children parent rating scales to look at emotional and behavioral health and adaptive skills for these kids. And we were able to have multiple time points for many of the participants in the study. For a small number of them, we had up to 10 time points. And what we found were that median scores were in the average range. So again, very reassuring that by and large, emotional and behavioral health for kids with mild to moderate CKD is in the average range. But for some of the subscales, we found that a higher proportion than expected had ratings a standard deviation or more from the mean. So kind of that same theme that we've seen all along. And here I just wanted to kind of show you on the BASC. These are the clinical scales on the BASC. And so we'd expect about 16% to be greater than or equal to 1 standard deviation above the mean. And that's true for many of the subscales, but for example, somatization, we found 32%, for attention problems, 28%, internalizing problems, 24%, and that is that's higher than what we would expect in a normal distribution or in the general population. And then when we looked at adaptive scales, and on this table, there is a typo. This should say a standard deviation below the mean because adaptive for the adaptive scales, the direction of the scale is flipped. But what we found was that for adaptive skills, about 32% had scores lower than we would expect, indicating some deficits there. And this was not a finding actually that we expected, so we're looking forward to kind of following up on this. We also found, as part of this BASC study, that GFR was not associated with emotional behavioral health or adaptive skills, but we did find that proteinuria and persistent hypertension were associated with inattention. So kids who had hypertension at multiple time points or hypertension that persisted, and then kids who had proteinuria were associated with their parents reported more symptoms of inattention than other kids. History of seizure was associated with more internalizing symptoms, and then glomerular disease was associated with fewer internalizing symptoms. And we speculated that that may be because they tend to have a shorter disease course at study entry. But that's something, again, that merits further research. In another study, depressive symptoms were not associated with GFR. So this is one where we had a separate measure of more extensive measure of depressive symptoms. And about 5% reported depressive symptoms, 2% reported they were in treatment for depression. So that's probably not super far off from the normal population. But what we did find was that, or what Kogan et al. Found was that for those who did report depressive symptoms, it was associated with lower IQ, lower academic achievement, poor self and parent reported health-related quality of life. All right, so again, that's kind of mild to moderate CKD, and the picture, of course, changes significantly as you move into end-stage kidney disease. So while mild to moderate CKD carries some disease burden and may impact functioning, or at least put kids at more risk, some of the kids for more risk of problems, ESKD imparts a much higher disease burden and a much more significant impact on social adjustment and emotional and behavioral health. So as children enter renal replacement therapy, school attendance declines for many of them. There are fewer opportunities for social development and socialization. They have increased dependence on their parents and medical professionals and less autonomy, especially for pre-adolescents and adolescents at the time in their life when they're supposed to be kind of pulling away from adults and having more autonomy and more independence. Often they have a lot less. They tend to have an impact on their self-efficacy, their self-esteem. There are often physical appearance changes associated with a more advanced kidney disease and dialysis. There are lifestyle restrictions that can be very difficult for children, even things that we may not think of as being a very big deal, like not being able to go swimming or eat the foods that you like. Those things can be very stressful for kids and families. There's a fair amount of uncertainty in terms of their disease course and whether or not they'll get a transplant. When will they be ready for transplant? When will that happen? And then their ongoing adjustment, they have reduced access to the things that we would normally recommend to help children cope with stressors, help them manage their emotions, like increased social support, extracurricular activities that really promote coping. Sometimes it's much harder for them to access those things when they are on dialysis. We find, and thus we find that kids who have ESKD have much higher rates of internalizing symptoms than those with earlier stage disease. In particular, dialysis patients have more depressive symptoms than transplants or controls. In a study that looked at kids on HD and PD, over half reported significant depressive symptoms. One study found a prevalence of psychiatric disorders at 52%. Depression and adjustment disorders were the most common, and the rate was much higher than a pre-dialysis comparison group. In long-term follow-up of kids who had ESKD in early life, they found that 50% scored in the borderline to impaired range on a measure of overall adjustment. And in a study of pre-dialysis, dialysis, and transplant, children with CKD had more parent-reported symptoms of emotional, behavioral, and peer problems compared to a healthy control group. And so they found in this kind of mixed group a prevalence of 57%. And for those who also reported poor quality of life, they had a higher prevalence of emotional and behavioral problems. So in terms of emotional and behavioral health, to kind of summarize, for children with mild to moderate CKD, emotional and behavioral health is largely within normal limits, although some of those kids tend to be a little bit more at risk for problems with emotional and behavioral health, particularly inattention. And as CKD worsens, there's a much higher risk for poor emotional and behavioral health and for psychopathology, and some comorbidities may increase that risk. What you don't see is in the literature is there does not appear to be a higher rate of what we call externalizing behavior problems. So while we might see more depression, anxiety, adjustment problems, inattention, there's really very little evidence that kids with CKD have higher rates of disruptive behavior or oppositional behavior, conduct problems, things like that. That's not something that you see. So they look the same as the general population. Definitely see that sometimes, but no, not at a higher rate than what you would see in a group of healthy kids. All right, so that brings us to kind of the third section of the talk, where I want to talk a little bit about quality of life. So quality of life is a broad concept that reflects an individual's physical health, psychological state, personal beliefs, social relationships, and relationships to important features of their environment. In the United States, we have several different measures that we use. A pretty commonly used measure is the PEDS-QL. We think of health-related quality of life as a multidimensional construct encompassing physical, psychological, social, and educational, vocational domains. And the PEDS-QL does map onto those 4 domains, so you get those 4 different scores. So again, kind of starting with mild to moderate CKD, in a cross-sectional study, in the CKID study, parent and youth reported lower health-related quality of life across all 4 domains compared to healthy children. So even in mild to moderate CKD, we saw slightly lower scores on health-related quality of life than healthy kids. Somewhat unexpectedly, we saw better ratings in the domains of physical, social, and emotional if the children had longer disease duration and older age. However, older age was associated with poorer ratings in the school domain, and GFR was not associated with health-related quality of life. When we looked at our quality of life findings longitudinally, we found that there wasn't a whole lot of change over time. So again, if you're looking just at kids with mild to moderate disease, their own ratings of health-related quality of life tended to be pretty stable over time. Again, they were on average a little bit lower than healthy children rate their own quality of life. And child ratings, so child self-report actually showed a slight positive trajectory over time, but parent ratings did not reflect improvement or decline. They tended to stay pretty stable. In contrast to mild to moderate CKD, you see a significant impact on health-related quality of life with children who have end-stage kidney disease. They tend to have significantly worse parent proxy and self-report ratings across domains for children who've received renal replacement therapy. And ratings are likely to be lower, in particular, for the physical and the school domains. So a lot of studies kind of lump together dialysis, transplant, sometimes pre-dialysis. But if we look at studies that report so that we can kind of compare. Several studies have reported that children on dialysis report lower health-related quality of life than those with renal transplants. So there does seem to be some evidence that when children receive transplants, they do have improved quality of life, which, it's not that transplant doesn't bring along its own set of stressors, but certainly perhaps less than when you have to undergo dialysis. There's some indication that those on PD fare somewhat better than those on HD, which may be a bit confounded by which children qualify for peritoneal dialysis. At least in the United States, for our patients who have higher, have fewer social resources or more social stressors, they often are on in-center hemodialysis. And many studies that I mentioned earlier lump them together. An exception to transplant looking better was a study by Splinter, which did not find differences across RRT overall, but rather it was the presence of comorbidities that predicted health-related quality of life. If you look at studies who have examined health-related quality of life longitudinally across kids who have end-stage kidney disease, scores increased from dialysis to post-transplant. So this is a study that looked at it more longitudinally instead of cross-sectionally. And if you look at the course of dialysis only, patients on dialysis longer, particularly females, had worse ratings of emotional functioning over time in one study. And in the same study, parents of older youth and youth on dialysis longer rated their children's quality of life as worse across domains. And they reported that school functioning deteriorated over time. If we look at long-term outcomes related to quality of life, this is a study that looked at quality of life outcomes for all Dutch children who started renal replacement therapy at less than 15 years of age, found that as adults, their mental health was similar to the general population. Those who had returned to dialysis reported poor physical quality of life. They were overall less likely to have had children, they had lower incomes compared to the general population, and they were less likely to be employed. And those who reported lower health-related quality of life, that was associated with disabilities, comorbidities, and unemployment. A number of qualitative studies have looked at quality of life. So this was a study of adolescents and young adults who were on dialysis or awaiting transplant, and themes that emerged from interviews with them included a sense of impaired self-worth, perceiving an uncertain future, feeling limited with regard to physical and psychosocial capabilities, and they perceived fewer opportunities for themselves and less potential that they would be successful. And when they used a visual analog scale, they reported significantly impaired quality of life and were willing to trade considerable life expectancy for perfect health now. So they were willing to cut years off their life in order to be healthy at this time and have a healthier life. And of course, dialysis patients reported the highest disease burden. In a review of qualitative studies that included over 1,400 kids, there were 5 main themes that emerged in this study, including a loss of control, a restricted lifestyle, the need to kind of mobilize and use coping strategies to cope with stressors, the burden of managing their treatment and feeling different from their peers. And the authors of this review concluded that children on dialysis tend to have poor self-esteem. They have a loss of identity, body integrity, and independence, and perceive their disease as limiting their opportunities in life. So I wanted to talk briefly about 3 comorbidities that can influence quality of life. And the first one is sleep. I talked about this a little bit with regard to neurocognitive functioning, but again, in this study, 77 to 85% of children on dialysis demonstrated sleep disorders. So it's a very common problem for kids with ESKD. They had high rates of sleep disturbance correlated with decline in health-related quality of life, independent of stage of disease or GFR. Restless leg syndrome is more common in children in all stages of CKD versus healthy controls. And parent proxy reports of children with restless leg syndrome reported poor psychosocial and overall quality of life scores. And then in that same study that we did looking at low energy and neurocognitive functioning, we found that fatigue was associated with poor emotional behavioral health. A second comorbidity that affects quality of life is short stature. So children with CKD and short stature reported lower self-esteem and lower satisfaction with health than those with normal growth. Studies of children with mild to moderate CKD and short stature find that it's associated with lower physical quality of life. Short stature has been associated with reduced likelihood of having children in that long-term follow-up study. And it's associated with emotional and behavioral, and again, in our study, this is actually a different one that we did looking at emotional behavioral health and short stature. And we found that generally short stature did not predict impaired emotional behavioral health, but it did predict increased somatization. So again, across many of the measures, the kids were within normal limits. These are kids with mild to moderate disease and short stature, but they did report increased somatization, which included fear of illness, complaints of pain, poor physical health, and illness. And then the third one that we have some data on is anemia as a comorbidity that influences quality of life. There's some evidence it's associated with reduced quality of life, including lower parent proxy scores for emotional quality of life. In another study, kids with hematocrit less than 36% were less likely to participate in school and social activities, and they were less physically active. And in another study, a self-reported reduced alertness had a negative impact on emotions and daily activities. All right, so I wanted to mention briefly the effects of kidney disease on caregivers, particularly caregivers of children who have more advanced CKD. Approximately 1/3 of parents of children on dialysis report clinically significant symptoms of depression and anxiety. Mothers may report more symptoms than fathers, and they do report higher parenting stress. Both mothers and fathers report high levels of parenting stress, but mothers report even more. Over half of one sample scored in the clinically significant range on a measure of global psychological distress. So certainly taking care of children on dialysis imparts a significant burden and can affect parent mental health. So some qualitative studies have identified common stressors associated with parenting a child with ESKD, including health system issues like sitting in waiting rooms, dealing with insurance, if you're in a country that has that, infrequent appointments, financial stressors, children or parents of children on dialysis have higher levels of unemployment, concern about their child's growth, development, and the appearance of their child, having to manage fluid and diet restrictions within the context of the larger family, educational difficulties and having to advocate for their child in terms of academic progress, a lack of social support, a sense of medicalized parenting. So instead of being able to kind of inhabit a typical or what they expected their parenting role would be with their child, they find themselves having to engage in a lot of very medicalized tasks and do things to their children that cause pain or distress, and they've described that as incredibly stressful. And then just distress and anxiety about their child's condition and their child's future. And then I wanted to just at least touch on sibling adjustment. There's actually really not enough research on the effect of chronic conditions, in particular CKD, on siblings. A small study of siblings indicated high rates, perceived disruption to their routine, feel jealous or left out, and 50% felt they could not openly share their concerns with parents. And that's certainly something that I hear clinically. I don't treat a lot of siblings, but I've treated a few over the years. And a lot of times there's a real reluctance to talk to their parents about problems or their symptoms or what's going on because they feel like they're kind of piling on when their parents are already very overwhelmed. Another small study found that even up to 10 years post-transplant, siblings reported decreased quality of life compared to healthy populations and similar to their siblings with transplant. So this is a study that Brad Wardy and I did that I mentioned earlier. And I was surprised at least to find that, even long-term and out several years from transplant, siblings reported almost as impaired quality of life as our patients did. And again, it was a very small study and would need to be replicated, but it was definitely an interesting finding. All right, so what are some supportive strategies for these kids? So one thing I think that we can do is make sure that we track the academic progress of kids who have CKD, especially advanced CKD, and provide timely assessment and intervention, and really strive to reduce as much as we can school absenteeism when there isn't, of course, a pandemic, and promote school participation. There are so many benefits to being in school and around peers in terms of social development, learning how to cope, receiving academic instruction, that it's really important that as much as possible we try to reduce that absenteeism. At Children's Mercy, we recommend for all of my kids who have end-stage renal disease, we recommend a pretty thorough psychology evaluation before they enter kindergarten, just so we can identify any deficits that they might have and be really proactive about advocating for accommodations that might be helpful to them. The other thing that I think is important is thinking about, and what I see clinically, is post-transplant. Sometimes kids get through that initial transplant period and the recovery, and the several weeks they're at home, and then they get back into school, and things kind of normalize a little bit. And then we find that at least a subset of them really struggle with inattention and difficulty with those executive functions that I was talking about earlier. And so just making sure to be kind of following up and tracking that progress and making sure they're doing okay, and then intervening if we need to. I think treating comorbidities is important. These appear to be associated with poor neurocognitive functioning and poor quality of life. So one example would be that many kids with CKD and short stature don't receive growth hormone therapy. And so this may be a potentially modifiable comorbidity that impacts quality of life. There are studies in adults and some small studies in children that suggest that more frequent dialysis or variations in how it is administered, for example, at home or nocturnally, can improve quality of life. So some of these studies have demonstrated some reduced comorbidities, kids being able to have a more relaxed diet, improved growth, increased school attendance. Of course, some of those modalities also impart a higher caregiver burden, so that has to be balanced. And certainly, in the United States, it's the exception, not the rule. Another thing that we can do is routinely assess quality of life and then target areas of poor quality of life to improve emotional health. So we have a mandate in the United States to assess quality of life. But I think it's very important that when we do, we then try to follow up on areas that are reported as poor and identify interventions that may be able to ameliorate some of that quality of life issue. Appropriate referral to mental and behavioral health professionals for assessment and intervention. This is, of course, more accessible in some areas or at some hospitals than others, but having that easy access to behavioral health can be very important. Providing caregiver and family support, and trying not to forget that the siblings are often just as impacted as their affected siblings. And then, of course, children on dialysis and their families are at the most risk. So maximizing supportive resources such as having a school teacher in the dialysis unit, having child life readily available, access to mental and behavioral health services, and really trying to collaborate with the family to prioritize some normative activities that are important to kids and really important for social development and coping. All right, and then I also wanted to, when I was putting together the slides of what to do, sometimes it feels a little bit overwhelming because so many of these families struggle so much, and there is only so much that we can do. And what's really needed are treatments that are less burdensome, and hopefully someday we will see those. But I also think that, I know I'm talking to many dietitians today and allied health professionals, and I think it's really important that that the work you do every day also really goes a long ways towards supporting these families. So when you allow a family to really feel heard, when you're flexible with your time, when you're genuinely collaborating with them on the treatment plan, that kindness and that compassion really makes a difference. And so I wanted to end by thanking you for all of the really good work that you do with kids who have CKD. All right, and so then I have my many references